I'm Rod Rohrich. I'd like to welcome you to this edition of the PRS Journal Club podcast with your hosts, Drs. Jordan Frey, Chad Purnell, and Dr. Shuja Shafqat. Please enjoy.
Hey everyone, and welcome to the October 2017 special Masters edition of the PRS Journal Club podcast. My name is Shuja Shafqat, PRS Resident Ambassador from the Fox Chase Cancer Center in Philadelphia. And as always, I'm joined by my co-resident ambassadors, Jordan Frey from NYU and Chad Purnell from Northwestern. Today we have the great honor of being joined by Dr. Rod Rohrich, the editor of Plastic and Reconstructive Surgery and professor and founding chairman of the Department of Plastic Surgery at the University of Texas Southwestern. Thank you so much, Dr. Rohrich, for joining us for this special Masters of Plastic Surgery edition of the PRS Journal Club podcast.
My pleasure.
So the article we'll be discussing next is entitled Facial Assessment and Injection Guide for Botulinum, Toxin, and Injectable Hyaluronic Acid Fillers focused on the midface from Drs. Maio, DeBoulle, Braz, and as well Dr. Rohrich from Brazil, Belgium, and UT Southwestern. And just for all our listeners, remember that this month's articles can be read for free on prsjournal.com, including an archive of all past Journal Club articles. The authors of this article start by discussing the importance of the midface and lateral cheek, as augmentation of this area can affect both the lower face and the upper facial structures in a positive way, and that fillers rather than neuromodulators are really the treatment of choice. However, risk of injection in the infraorbital artery or perinasal vessels is a risk in this area and should be handled with caution. And it should be noted in this article that the fillers discussed are mostly Allergan fillers. These are the ones that the authors have the most experience with. So, just as some background information, the first signs of aging around the eye with excess skin and bags from laxity of the orbital septum and pseudoherniation of fat. As we know, a depression or indentation can occur at the junction of the thin eyelid skin and the thicker cheek skin. Volume loss and loss of support can be seen, and that can create a flattening or a concave profile of the midface. And the authors also discuss the tear trough deformity as well as loss of the lateral and superior fat in the midface and prominence of the inferior medial fat. So for assessment of the midface, it should be noted that patients should be assessed in rest and at animation, and loss of fat and malar projection should be noted. And one interesting measurement that is mentioned in the article is that the ideal maximal point of projection of the cheekbone should be 10 millimeters lateral and 15 millimeters inferior to the lateral canthus, which is a good target for augmentation. So now the authors go into different injection techniques into different anatomic areas, which I won't excessively belabor, but I think it's really a worthwhile article to read and especially look at the figures, which are actually very excellent. So in the upper cheek, we can do supraperiosteal injections over the zygoma with care to avoid the zygomaticofacial vessels. In the anterior cheek, the injection is deep subcutaneous or supraperiosteal with intention paid to the location of the infraorbital vessels. And obviously we want to be below the arcus marginalis and out of the eyelid. The medial cheek is a similar injection lateral to the mid-pupillary line, but it was recommended in the article to use a blunt cannula medially to the mid-pupillary line due to the risk of inadvertent vascular injection. For lid-cheek junction injections, these are also placed supraperiosteally, usually 1 to 2 millimeters below the rim, but the authors note that in the thin skin of the eyelid, you can have significant bruising, edema, asymmetry, and obviously catastrophic embolization causing blindness by retrograde injection, so they should be clearly approached with caution and by those with experience. The submalar area can also be filled, where fillers are placed usually more subcutaneously to avoid the deeper structures like the facial artery and vein, the parotid duct, buccal branches of the facial nerve, and the authors note that intraoral massage should be done in this area to prevent irregularities. Preauricular injections can be done, and those are usually in the subcutaneous plane as well, but the authors note that due to the parotid cutaneous ligaments in this area can be difficult to correct all the deficits. Obviously, anatomic structures to be wary of in this area, parotid gland and the transverse facial artery, and this is another area where a blunt microcannula can be considered. And actually the part of the article that I thought was most interesting was the nasal augmentation part. We all know that the nose is a critical aesthetic structure, and use of fillers can be an excellent adjunct for post-rhinoplasty refinements or even primary augmentation of the nose. As the nose ages, the nasal tip droops, the lower third of the face becomes relatively shorter by comparison, the maxilla becomes less projecting, and the dorsum becomes more prominent. Most of us are familiar with nasal evaluation and also with the vascular anastomosis around the nose that can be devastating if injected. Frontonasal injections can be accomplished in patients who have deep radix and be used to make the nose appear somewhat smaller. This is again done in usually a supraperiosteal location with avoidance of the filler traveling laterally off of the dorsum when taking care to avoid the supratrochlear and supraorbital vessels. Dorsal augmentation is also a more commonly described procedure where the bony dorsum can be augmented as well as the cartilaginous dorsum. And obviously here the dorsal and external nasal arteries are critical to avoid with excessive and especially excessive injection in the supratip area, which can create a deformity. The nasolabial angle can also be altered with injection around the anterior nasal spine, but again, taking care to avoid injection into the septal cartilage or the columellar branches of the superior labial artery. And also they know excessive injection can elongate the upper lip in this area. For patients with retracted columellar or flaring ala, the columella can be augmented with an injection in the anterior cartilaginous septum while avoiding the nasal tip. And then the conclusion of the article talks about Botox and use of Botox for bunny lines around the nose and elevation of the nasal tip by paralysis of the depressor septi nasi. But again, the authors state that fillers is more the treatment of choice for augmenting the midface. So it's kind of a brief overview. I know I skipped over a lot, but again, I urge everybody to read this article and look at the figures because it has some really great pointers. So overall, I thought this was a really excellent paper. This basically summed up everything I wanted to know about injectables when I was in residency and training, specifically what kind of deformities can be corrected, with which injections, how to do them properly, which structures you're trying to avoid in those areas, which plane you're trying to put them in, how to avoid complications. As you read the paper, you can see that there's certain techniques or certain things to do anytime you do injectables like massage, care with the underlying structures, things like that. I think it's a really great paper for residents or junior attendings, especially people who are just starting out in practice or just starting to do these, to do them safely and reliably and have reproducible results. I also think it's useful because it talks about a lot of the things that pop up on our exams, either boards or in service, specifically anastomoses between the external and internal carotid systems around the nose and the risk of injectables into this area. I've done some fillers in residency. In our cosmetic clinic, I think that the upper cheek filler injections over the zygoma periosteum is a really powerful tool, and they can have a pretty dramatic effect on changing the shape of people's faces, blunting nasolabial folds and things like that, especially with the hyaluronic acid fillers that tend to be more hydrophilic. And also, I think the use of the microcannulas, the blunt flexible microcannulas, is actually very easy. It causes less pain, and it's much safer for the patient. So with that, I'll turn the discussion over to the group, and Dr. Rohrich, if you have anything to add to this article. And then I wanted to ask you specifically about complications. People talk a lot about how they manage complications, hyaluronidase, massage, things like that. So what kind of complications from fillers have you personally seen, and what is your usual treatment algorithm if somebody has a complication?
I would just say that the blunt cannulas or needles, they both have a role. The only thing is, don't be lulled into complacency or safety that cannulas are safer. The challenge I see with cannulas is that people think they're safer, and yet there's been as many severe complications with cannulas as with needles. So you got to be careful. Most complications occur proximal to the cannula or the needle. That's the injector. My advice would be, and the reason we wrote this article was that go in the safe areas, that the malar areas, the 3-point on the arch, the zygoma, and then the deep lateral compartment, and then start working around the perioral, the commissure areas. All of these areas where, as plastic surgeons, we know the blood supply is deep, especially in the commissure and below, the facial artery is deep to the mimetic muscles. But when you do see complications, and if you're going to treat, and every one of you should be using neuromodulators, but I would highly encourage you to use the biodegradable, the reversible fillers so you have an antidote, and that antidote is hyaluronidase. So don't inject fillers without having hyaluronidase. So if you see blanching, pain, immediate discomfort, or anything that's tissue loss until proven otherwise, you must stop. And the most important thing is to flush it. Have the hyaluronidase there and flush it with 100 to 300 units of hyaluronidase until it's pink. Don't let the patient leave or anything until everything's pink. You've got to do that immediately. Ice won't work, nitropaste, or any of those things. You can do aspirin and all those things afterwards, but they got to be pink. You got to flush it out of there. Now, if there's a blindness issue, that's a totally different arena and topic. But I've seen tissue compromised in patients that have been referred in to me like the day later. Some of them have been great injectors. But that's why I always encourage my patients saying if there's any pain or discomfort, usually you'll see it 9 times out of 10 immediately. But the danger zones, and I think all of you have probably read, the article on the danger zones, but the nose and the nasal labial fold and the base of the alar base are very, very important danger zones, as is the glabella. Don't inject superficial in those areas. Inject superficial in the glabella, only deep in the nasolabial fold, up high into the periapical area. And then the nose, stay in the midline and stay deep. Does that make sense? Do you have any questions about that? But the most important thing is start slow, like for a nose, which is a very potentially dangerous area. Do small incremental amounts. Stay in the midline. Stay deep. And, monitor the patient.
That's excellent advice. And you kind of harped on a lot of the things that come up in the article in terms of things to watch out for. Again, staying in the right plane, staying in the right location, make sure you don't travel out of the safe areas and into danger areas. And the figures in the article are really great. They show you where the injections are supposed to be and where the vascular structures to watch out for are. So I think it's a really great summary, and thank you for that. The next question I wanted to ask is, there's been a lot of discussion about cosmetic experience in residency. Certainly everybody has different exposure to that. Some people have clinics, some people don't have clinics, some people have variable experience. What do you think is the ideal way for residents to learn how to do these injections properly and safely before even going out into practice or starting as a junior attending?
I would tell you the most important thing to do is go travel or go and spend a day or two with somebody that does a lot of fillers, whether it's a board-certified plastic surgeon or a highly respected dermatologist. Spend a day or two with them. Our residents spend a whole month with me, so in the morning and the afternoon they operate with me in the afternoon to watch me do fillers. So spend time with somebody that can teach you how to do fillers safely, and then start slowly. Use hyaluronidase fillers, use the hyaluronic acid fillers, and don't overdo them. I see so many patients that have been overdone. Go slow. You will build an incredible reputation in practice by being honest with your patients and saying no. I see that every day where people want too much in their lips, too much in their cheeks, and you got to tell them that you're a doctor first and that you're there to protect them from themselves sometimes. And we see this all over the country. I see it in Dallas every day.
That's great advice. Thank you. Chad, what did you think about this article?
I really like this article, and I got to say, of all the articles that I've reviewed for PRS Journal Club, this is the first article that I've actually used in practice already before I'm even talking about it here in the Journal Club. In my resident clinic, I do a lot of filler injections, and I've definitely seen a lot of patients who want midface augmentation. And I have referred back to this article multiple times already because it's a great review of the anatomy. It's a great review of techniques. And it just so happens that they use the same products in this article that we use in my clinic. And so it really was immediately applicable to me. So a great article. Dr. Rohrich, one thing I wanted to ask you about was in that vein, when we're starting out, there are so many different brands of fillers. There are so many different types of fillers, different G primes, all these different things. And so whenever someone's starting out in practice, how many products do you think they should familiarize themselves with, and what's a good toolbox to start with?
That's a great question because it's almost starting like Europe, but now here where there's 90 or so fillers and neuromodulators. But I would say get to know 1 or 2 great hyaluronic acid fillers and, start with the Juvederms and the Restylans. And then once you're becoming very facile with them, you know that some of the softer fillers work well around the lips, the Juvederms, and then you can graduate to Glabella and others. And, I don't have any conflicts of interest on this, by the way. I don't have any, interest in any of these companies. But start with a small number that you're very familiar with and that they're safe. And all of the FDA-approved hyaluronic acid fillers are safe. And they have a specific role. Some, of course, like Voluma and Restylane Lift, they're bigger, so they have a bigger G prime, so you have to go deeper. But just pick one of those and then use it and become very good at it for the lips. And then one for the tear trough. Like the tear trough, the Restylane is better because it is not hydrophilic. And then pick one that's very superficial, a Volbella or a Restylane Silk for a superficial. But pick one of them. It doesn't matter, but use it and become proficient. Because there's so many out there now. And, now with the new family of fillers coming out, the Velour and others, and it can be confusing. Pick one or two, become familiar, and then when you want to branch out, talk to people that do it. Call people like me or email me. I'll tell you exactly where it works and where it doesn't work. The problem with the FDA labels, as you know, is they're all approved for the nasolabial fold. The rest of it's off-label. I inject off-label 95% of the time in most of my patients.
I think that's great advice. It is a little overwhelming at first, so I think if you get just a few products and learn to use them well, that seems like the most logical way to approach it.
It's a marathon, not a sprint, okay? Just like life, just like plastic surgery, and just like the filler market, I introduced the first hyaluronic acid filler in 2004, and now we have, over 20.
It is growing at a pretty crazy rate now. So, Jordan, what did you think of this article?
I had the same opinion as everyone. I thought it was a great article and extremely practical article. I actually had the same exact experience as Chad. You were saying, I read this, I think one morning I had some time before the resident clinic started as I'm on my aesthetic rotation. I just happened to read this article kind of preparing for this, and then saw throughout the course of the day 5 or 6 filler patients, and was able to refer back to what I just read and really picked up some great tips, and then also learned some things that I'm still looking forward to try. So I really enjoyed it. Extremely practical and great guide that you can just read in 15, 20 minutes and then really learn a lot. Dr. Rohrich, a question on, as we take a step back and kind of a broader view, just as you've been saying how the filler market has really kind of expanded and there's a lot of patients presenting for filler injection, and how can we as plastic surgeons advocate for patients in choosing an experienced injector, as the paper and you've mentioned really requires a complete understanding of anatomy and technique for a successful outcome, and you really can have bad complications. So how do we advocate for patients or make them aware that they should be choosing an experienced injector?
That's the billion-dollar question, obviously, I think first and foremost, your best marketing is having a happy patient that you've done safe fillers on and not overdone them and done them in a safe manner. And spreading the word, that we want people that, are in the cosmetic medicine arena, that are board certified in plastic surgery, dermatology, oculoplastic, and facial plastic surgery, that are trained to do these fillers. Every one of these fillers requires a little different nuance. But once you have the experience and expertise in, the general fillers, it becomes easy to do. But I think, advocate for board certification. I see patients every day that have been to spas and all these other places that, who knows what they're injecting. Sometimes they're injecting things that aren't even legal in the U.S. because there's no oversight. So I think you just have to advocate for patient safety and do it on social media. And I think we're trying to do that. And, of course, recently there was an article that said that most of the people that are on social media aren't even plastic surgeons. But I think we're trying to do that through our societies. And I think you guys are really the ones that need to pave the way, because social media is the new way of people reading what's going on in the world. How many of you come home and watch TV? I don't. People don't do that anymore, They already know the news from the day. All of you probably have it on your iPhone. So that's how you get to the consumer.
Yeah, I think they're really great points, and there are a lot of new avenues to reach out to people, and it's important for us to really advocate for the specialty and for the patients, importantly. So I'll throw it back to Shuja.
Thanks, Jordan. I think that was a really good discussion. I agree with what everyone said. I think it's a very practical article. I remember when I first started looking at and doing injections in our cosmetic clinic, and it's very hard to find good practical advice or techniques on fillers and Botox, and something that we don't necessarily get a great training of or see a lot of in residency, who spend so much time in the operating room. Sometimes we don't get to see some of this. So I think it's very hard to find good practical diagrams and step-by-step instructions on how to avoid complications in these fillers. So I think this is a must-read for senior residents and junior attendings who are doing this in their practice. I think with that, we'll end our discussion of this article. Remember to tune in to the other 2 articles we'll be discussing on this month's podcast, as well as all our previous and future podcasts broadcast every month. And everyone, don't forget to participate in our monthly hashtag PRS Journal Club on Twitter, where we'll be able to interact directly with this month's selected articles' authors. And once again, thank you very much, Dr. Rohrich, for joining us for this inaugural Masters in Plastic Surgery PRS Journal Club podcast.
My pleasure.